Welcome to AETCM, the Emergency Medicine channel. Myself Dr Cecil. I am presenting the topic salicylate poisoning as a part of EM Rapid 2024. Aspirin and other salicylates are among the oldest medications in clinical practice, and their usage has been declined as NSAIDs are developed. So, coming to pharmacology, the sources of salicylates include: first one is aspirin. Aspirin is acetyl salicylic acid which is rapidly converted in vivo into salicylic acid. Second one is methyl salicylate. It is used as a flavoring agent and most commonly used in liniments and ointments. So, 5 ml of oil wintergreen contains 7 gram of aspirin, which is deadly to a toddler. And third is bismuth subsalicylate. It is a common ingredient in antidiarrheal agents. And the fourth one is magnesium subsalicylate, which is found in over-the-counter NSAIDs. And the last one is salicylic acid, which is used as a topical keratolytic agent and wart remover. Coming to pharmacokinetics, first one is absorption. So, aspirin is readily absorbed from the jejunum and to a lesser extent from the stomach and duodenum in the therapeutic dosing. So, peak concentration in the blood will be reaching by 1 hour with regular tablets, and it will be prolonged if we are using unrecorded or delayed release formulations. In toxic doses, peak concentration are frequently delayed because of the pylorospasm or the bezoar formation, that is concrete formation. And peak concentrations following injection of delayed release or entry-coated formulation occur between 4 and 14 hours. Coming to distribution, aspirin is hydrolyzed to salicylic acid, that is salicylate, which is of which the 50 to 80% of which is bounded to proteins, and it is distributed among the tissues. So, as the salicylate concentration increases, the saturation of protein binding sites also increases, and it will result in free or unbound salicylates, and only the unionized salicylate can cross the cell membrane. So, if there is metabolic acidosis, it will increase the non-ionized fraction. So, it will increase in brain salicylate concentration. Coming to metabolism, in therapeutic dosing, it follows a zero order kinetics with a half life of 2 to 4 hours. And aspirin and methyl salicylate, which are hydrolyzed to salicylic acid, it is metabolized by glucuronidation, oxidation and glycine conjugation. As concentration increases, hepatic detoxification enzymes become desaturated and the rate of metabolism reduces. So, elimination becomes slow, and it is by renal excretion. As said, kidneys will excrete the salicylic acid. The toxic doses, if it is less than 150 milligram per kilogram, there will be no symptoms or minimal symptoms, and from 150 to 300 milligram per kilogram, there will be mild to moderate toxicity. 301 to 500 milligram per kilogram, there will be severe toxicity, and more than 500 milligram per kilogram, it is potentially lethal. Coming to pathophysiology of salicylate toxicity, it can cause local gastric irritation, reversible ototoxicity, stimulation of chemoreceptor zones, and stimulation of medullary respiratory centers, stimulation of skeletal muscle metabolism, uncoupling of oxidative phosphorylation, enhancement of lipolysis, inhibition of Krebs cycle, increased vascular permeability, mobilization of glycogen stores, and inhibition of gluconeogenesis. We will come to this. So, coming to clinical manifestations, the earliest symptoms of acute salicylate poisoning will be including like tinnitus, nausea, vomiting, that is within 1 to 2 hours of ingestion. And more significant intoxication may cause tachypnea, hyperapnea, hyperthermia, diaphoresis, altered mental status, non-cardiac pulmonary edema, seizures, and then coma. Then coming to acid-base derangements, initially it will cause respiratory alkalosis, that is salicylate will directly stimulate the respiratory center, which may cause hyperventilation, and then carbon dioxide washout will happen. So, it may cause respiratory alkalosis, and then it will cause a high anion gap metabolic acidosis, and then it causes a respiratory acidosis where the PCO2 will be retention, PCO2 retention will be happening. So, salicylate affects both central and peripheral glucose homeostasis, and salicylate mobilization of salicylate will cause mobilization of the glucose stores, which may cause hyperglycemia. Also, it is a potent inhibitor of the gluconeogenesis. So, normoglycemia is the most common in toxicity, and it can cause corrosive injury in gastrointestinal tract with abdominal pain, nausea and vomiting. Gastric perforation after a significant acute aspirin injection can occur. Coming to severity grading, in acute ingestion there will be doses and then end organ toxicity, which all organs will be affected. In mild, it is less than 150 milligram per kilogram. It may cause tinnitus, hearing loss, dizziness, nausea and vomiting. In moderate, that is 150 to 300 milligram per kilogram, there will be tachypnea, hyperpyrexia, diaphoresis, ataxia and anxiety. And in severe, that is more than 300 milligram per kilogram, there will be abnormal mental status, seizures, acute lung injury, renal failure, cardiac arrhythmias and shock. Coming to diagnosis. The diagnosis of salicylate toxicity is made by a careful physical examination and diagnostic testing. So, the diagnosis is confirmed by a supratherapeutic serum concentration, that is more than 30 milligram per deciliter. Toxicological testing, that is there will be changes in serum concentration of salicylates which can lag behind the development of clinical signs by hours. So, we have to obtain serial salicylate concentrations approximately every 1 to 2 hours until the concentrations are declining or the patient's clinical state improves. And additional testings can be including electrolytes, glucose, blood urea nitrogen, creatinine, ABG, chest X-ray, ECG, CBC, serum calcium levels and urine analysis. Treatment includes first the general measures, assess the severity of toxicity, then immediate resuscitation with our ABC, that is airway breathing and circulation, correction of volume depletion and metabolic derangements, GI decontamination, reduction in body salicylate burden. So, this is the severity of toxicity. As we told, there is mild or early toxicity, moderate or middle toxicity and severe or late toxicity. Symptoms of mild include tinnitus, nausea and signs will be tachypnea, mild hyperapnea and or tachycardia may start to develop. Mental status will be normal here. In serum salicylate concentration will be 30 to 50 milligram per deciliter. Blood pH will be normal or alkalotic. Urine pH will be more than 5. In moderate toxicity, the symptoms will be vomiting. The signs will be mild hypothermia, tachycardia, hyperapnea, diaphoresis. The mental status will be mild disorientation may start to develop or it may be normal. Serum salicylate concentration is 50 to 90 milligram per deciliter. Blood pH will be alkalotic. Urine pH will be less than 5, that is acidotic. Then severe or late toxicity symptoms include confusion and the signs will be hypothermia, cerebral edema, pulmonary edema, hypotension. Mental status will be patient will be altered mentation, disorientation, agitation, coma, seizures can occur. Serum concentration will be in acute toxicity, it will be more than 90 and chronic toxicity it will be more than 60. Blood pH will be acidotic and urine pH will be less than 5. Then airway breathing and circulation and other supportive management. That is airway breathing management, mostly we have to avoid tracheal intubation and it should be reserved for patient with hypoventilation or for patient who requires an airway protection such as in seizures, coma or agitation. And tracheally intubating a patient can result in periprocedural cardiovascular collapse and cardiac arrest. And also RSI can exacerbate the acidosis, that is administration of induction agents and neuromuscular blocking agents can prolong the make an apneic phase. And if at all if that is required, perform an awake intubation, that is without a neuromuscular blocking agents to avoid an apneic period. Post intubation ventilator management should maintain a high minute ventilation and adequate oxygenation should also be done. Then hydration, resuscitate aggressively with crystalloids unless there is any contraindication like cerebral edema or pulmonary edema. In toxic adult patient, more than 6 liters of fluid should be resuscitation. More than 6 liter resuscitation should be required. So, we have to give a normal saline at a rate of 10 to 15 milligram per kilogram per hour for the first 2 to 3 hours and then check the maintain a urine output between 2 to 3 milligram per kilogram per hour. So, the fluid resuscitation should be based on that. IV bolus of sodium bicarbonate, that is 1 to 2 milliequivalent per kilogram followed by a continuous infusion of 3 ampule of either 44 or 50 milliequivalent per ampule of sodium bicarbonate added to 1 liter of 5% dextrose in water can be given. Give supplemental, that is any potassium magnesium deficiencies are give the supplemental potassium and magnesium and correct the hypoglycemia if there is. Then hemodialysis, extracorporeal technique of choice for the treatment of serious salicylate poisoning. It is a choice because hemodialysis can correct the acid base disorders and electrolyte abnormalities while rapidly reducing the salicylate burden. So, indications are clinical deterioration or failure of improvement despite intensive support care, lack of success of alkalinizing serum and urine, renal failure, severe acid base abnormalities, altered mental status, acute lung injury, serum salicylate concentration if it is more than 100 milligram per deciliter and in acute and more than 60 milligram per deciliter in chronic, and symptomatic patients with lower serum salicylate concentration. Disposition and follow up symptoms, when to dispose, that is if the symptoms are resolved, normal vital signs and examination have seen, and 2 downtrending salicylate concentration which is less than 30 milligram per deciliter. So, this is all about salicylate poisoning. Thank you.